AI is being rolled out in healthcare at an unprecedented rate with applications like ambient scribes, patient record summarizers, and AI charting. Like other academic health systems, UT Southwestern has AI governance groups in place to ensure that AI is deployed thoughtfully and safely and affordably, and to monitor its use and performance. I've been thinking a lot about my role as the Chief Learning Health Officer in the implementation and evaluation of AI. One of the main questions health systems are asking about AI is, are we realizing the value of the investment? The Learning Health System Framework is a guide for monitoring performance and gaining insight from the use of a solution like AI in practice, assessing its value, refining or decommissioning the solution, monitoring and learning, and continuing the cycle. We can readily collect a lot of data from the AI tools to assess their accuracy and their impact on clinician time. Many studies look at clinician experience and even decision making, but we're just at the beginning of determining whether they're providing the value that we hope for. A recent paper points out that we're still struggling to determine which tools are worth the costs of money, time, and political capital. These trade-offs are often framed in terms of return on investment, or ROI. But ROI is not as straightforward to measure for AI tools being used by clinicians. It's early, and we're still generating the evidence base, and it's hard to measure things like enhanced patient experience or benefits to reputation. For example, a 2020 study assessed an AI-based software that triaged mammograms. They showed they could cut the radiologist's workload in half and detect more cancers earlier. What wasn't measured, but may also be important, is improved retention of radiologists or the risk of missing a tumor diagnosis without the technology. There's a long view of ROI for AI as well. Even if early AI tools like scribes or prior authorization drafting yield minimal financial returns, gaining clinician buy-in for AI adoption may pave the way for later adoption of tools that have better ROI, like those that aid in diagnosis or clinical decision-making. The Clinical Informatics Fellowship Program has a weekly leadership journal club that meets with the health system informatics leadership, all of the CMIOs, deputy CMIOs, and associate CMIOs that are available for lunch. And this week I picked their brains about the types of evaluations that would add benefit to our understanding of AI's value to clinicians, the system, and patients. They described a variety of assessments that they would like to see. Here are some of the questions they have about AI use in their clinics. How is AI changing the relationship between physicians and patients? Why are some clinicians not adopting certain AI products they have access to? How can we learn from that? AI is now generating text that goes into the medical record. Are there unintended consequences like amplification of certain observations or findings? How usable are the reports being generated by AI for different audiences? How is AI charting changing training of residents in note writing? How is it changing the role of the attendee in assuring that residents learn to chart? It would be too expensive to evaluate everything, so how do we prioritize what to measure? A high-functioning learning health system would systematically consider benefits and costs of AI over different timeframes. But that will require new processes, new infrastructure, and I would posit new people. It's a perfect opportunity to build tighter collaborations between healthcare operations and quantitative and qualitative researchers.